So I'm delighted to be here. Thank you very much, Susan, and the organizing committee for inviting me to present to you some interesting and I think challenging project that has to do, and this is this. Well, I'm going to talk over here on the English side. The title that you gave is a bit long, and she was almost out of breath. So I changed the title, and just to the short title, which is Improving Patient Experience and Health Outcomes Collaborative, which we call iPEHOC when we have our weekly teleconferences and so on. The project is really about engaging patients, but also looking at symptom management and finding ways to do this in an effective way to help patients and the healthcare team move more rapidly through the conversation. I'm going to give you a little bit of background, and then I'm going to show you a short video clip, and then give you just a very brief outline of what we're doing, just to whet your appetite. This really is a very complex project that involves the Rossi Cancer Network, the 3 hospitals, including the MUHC, 3 hospitals in Ontario, including Princess Margaret, as well as First Nations, Inuit, Métis. So the Canadian Partnership Against Cancer is funding this, and they're getting a big bang for their buck, believe me. So the Rossi Cancer Network, just very briefly, is a collaboration between the 3 McGill hospitals and the Faculty of Medicine and funded by the Rossi family over 10 years to improve the quality of cancer care received by the population served by our teaching institutions. Of course, things are changing very rapidly, as you know. And the vision is to develop the network as a world-class comprehensive cancer center with outcomes in survival, mortality, and patient satisfaction and patient experience. I actually did not like the vision statement because I think it should be patient experience, not just patient satisfaction, as good or better than the best international comprehensive cancer centers. So we know that distress is a big problem amongst our cancer population. And the results of many AOPS surveys across Canada and locally have shown that emotional... Is this also a pointer? No.
It is, but if you point on one, it can't be seen on the other.
I'll point on both. Whoops. Sorry.
This one is not.
Okay. All right, anyway. So the results, if you can see in the middle, and I hope you can see the one that's circled, is that amongst the various aspects that are measured in terms of patient satisfaction in the ambulatory patient satisfaction survey, that emotional support is the least well endorsed amongst patients across the country. And ours at Rossi are really very comparable to national.
I'm trying to synchronize your slides. If you press on this, it will advance both. You don't need to do it from there.
I see. Okay, sorry.
Like this.
I'm challenged. If I could tell you what I did at lunchtime. Never mind. Okay. So the iPEHOC project, as I said, is funded by the Canadian Partnership Against Cancer, a 3-year project that in general is designed to, with a number of projects, 15 projects across the country, to look at person-centered approaches to care. And our project, as I said, involves cancer care centers in Quebec and Ontario. And the basic objective is to develop a standardized and sustainable, and I want to underscore sustainable because we're a year and a half into the project and we're already looking at sustainability. Patient-centered measurement system to improve the patient experience of cancer care, and something that will be applicable across all jurisdictions in Canada. So somewhere there was supposed to be a slide, a placeholder slide, and I think but I guess you took it out. So could you show the video now, please? I have a short video that I think will describe very well what it is that we're trying to do, and this is a patient rep from Sudbury who came to talk to us at our workshop in Montreal, in Toronto in last March, and I think that in this very short clip, I think you'll hear the message. Go ahead. Yeah.
So as clinicians, you have a ton of experience You have vast knowledge and great access to resources such as academic resources, psychosocial, personnel, so on, to help reduce, remove, and manage your patient's troubling symptoms. But however wonderful and reassuring that is to the people who are current patients or past patients such as myself, that you have all this wonderful knowledge, the onus is on us as patients to plug in, to actively engage, and to pass along that information about what is distressing us, what is hurting us, what is preventing us from feeling our very best in spite of our cancer diagnosis. There's a problem, though. We are sick. We are fatigued. We are overwhelmed. We are forgetful. We are foggy and uncertain. We're frustrated and flustered. Our symptoms may be intermittent in frequency. We may not be sure if the symptom is just a sign of aging. We don't want to bother the good doctor or be perceived as a complainer. We are in denial of our symptoms. Our head is in the sand. If we don't say it out loud, it doesn't exist. We are embarrassed to be this weak. Or we may be so crippled by depression that we just either don't care or we are paralyzed to inaction. We are accustomed to the symptom and we think it's normal. Or we don't want to mention just how bad it is because we are protecting the caregiver in our lives from additional worry and burden, and so on, and so on, and so on. This is why we need a proper, reliable, comprehensive, and easy to use tool that prompts us and then helps us to access the care and support that you are so ready to offer to us. It also normalizes the idea of talking about your symptoms. It becomes normal then. It's not just something on the side. Whole person care means looking at my emotional and physical symptoms. It means exploring how I am coping with these symptoms and the overall coping with having a complex diagnosis. It means look and hear me, the visible me right here in front of you, as well as the invisible me, the emotional side, the mental sides of me in front of you. Screening tools help give your patients a voice, which in turn can help you immensely care for them. So we hold the key as patients to how and what we are feeling. You hold the keys to how to make us feel better. We can't deny that. And we both need an effective way to communicate.
So I think that that was probably the most eloquent, short message, and I think I still listen to it, and I'm still astounded at how well. This was part of a slightly longer presentation that she made to us, but I think this bit really captures what Tom Hutchison talked about this morning, what others have talked about this morning in terms of that communication piece. And I think it has guided us to some degree. This was sort of in the middle of our deliberations. She's one of the patients we've been working with. There are 4 other patients across the network, caregivers and patients who've been involved from the very beginning in this project and continue to be involved on our steering committee and at various levels in terms of developing our tools and our educational materials. And we certainly thank them for their input. So what are we doing? What we're doing is we are developing internet-based, IT-based measures, the ESAS-R, which is the Edmonton Symptom Assessment Survey, which many of you may know, which is a screening tool of 10 symptoms, coupled with and integrated to 4 patient-reported outcome measures, which are also widely used, the PHQ-9 to look at depression symptoms, the GAD-7, which looks at anxiety symptoms, the brief pain inventory, and fatigue. Screening has been used for a long time. One of the biggest criticisms about screening is that it's not sufficient to achieve person-centered care. Just screening by itself doesn't do anything. It highlights something, but if nothing happens with it, then there's no point in doing it. There's no point in spending the time or the effort. So a coordinated evidence-based response to distress needs to be implemented in a planned and systematic way. That was the message that I think you heard, and that's what we've been trying to work on with our colleagues in Ontario. So the idea is to screen with the pros, to review the results in real time, to develop intervention from evidence-based practice, and to follow up and see if our interventions actually have some impact. So this project, we've just started our pilot project in 3 hospitals here in Montreal, in the Rossi network. We started at St. Mary's several weeks ago. We started the Jewish last week. We have, hopefully we'll be starting here at the MUHC. You heard Dr. Biron speaking earlier about the need for doing these things electronically in real time, and I think here we have the beginnings of a tool that we can use, and we've been implementing it in real time. It has many challenges, believe me. It's not very simple. We're using iPads and touchscreen technology linked to a server to which the patients enter data. They check into their clinics. They complete here the DART tool, which we've acquired from Princess Margaret Hospital, which presents the ESAS, and then through intelligent programming, depending on the cutoff scores, will introduce a prom if necessary. So they won't get all the questionnaires every time. If everything's okay, they'll only do the ESAS and a social inventory once every 3 weeks if necessary. And then this will be used as an additional distress and symptom screening tool, administered, and once the patient completes the scale, the results are automatically printed and summarized into an output that, again, through intelligent programming, will show in an ongoing way over visits how the patient is doing, both on the ESAS on the left side, on symptom scales, and also on if they've completed the pain, fatigue, and emotional distress scales. You'll see that as well. So this is an output, a mock output, over 5 or 6 sessions. Since we just started, we actually don't have these yet, but this is what the output essentially looks like. This is given to the patient will take it, or the nurse will take it from the printer. We're hoping that this will ultimately go directly into the electronic health record. We don't have that technology yet, but it's taken and looked at by the nurse and or the doctor. We've screened about 100 patients so far. So far, the experience has been quite encouraging. Most patients take to it, even elderly, even very ill patients have taken to the initial one and been, we've gotten a good response. What we do, of course, is this is just a diagram of the flow. A patient puts in their identifying information, they get an introduction, there's a consent, and then there's an algorithm for how often they get each of the scales. There's a time factor. We don't give if the patient's seen twice a week for their pain, they'll only fill out the scale once, for example. There are time factors as well as algorithms related to the actual score. And of course, we act, and the idea is to act instantly and to refer the patient, either to deal with the patient at the moment or refer the patient immediately. Our patients have been involved at all levels, as I've said. This is the pamphlet, the introductory pamphlet that's been given to patients. And I have to tell you, it didn't look like this about a month ago or 6 weeks ago. It was developed in Toronto. Our patient rep here looked at it and said, "Oh, this isn't going to work. It didn't look right." She worked with it. She worked with some colleagues that she had some in the graphics industry, and she really put this into a format that was very accessible, much more accessible than what was designed previously. We have reminder tools. The one at the bottom on the right is a reminder about the project and for reminding the patient for the next time when they come for their next visit. So there is a participatory approach. As I said, patients are involved and engaged. They are involved in the patient education working group. Some educational videos have been developed, which were just completed today. And if I could download them on my phone, I'd show them all to you because we just got them today. 2-minute videos for clinicians and for patients that help clinicians and patients learn about how to interpret the data, how to use the data, and how to move forward in the patient care. We have a symptom management coordinator that we've hired to begin the process of integrating this. Sustainability shouldn't be too difficult. It probably won't be that expensive because the hardware and the software have all been designed and developed and integrated. Once we're through and the money runs out of the project, it shouldn't cost too much to keep it going. At least that's what we're hoping. So, why are we doing this? Well, we're trying to change the conversation. Change the conversation, as the patient said in the video, in real time, to facilitate individual tailoring of care, symptom assessment. So rather than the doctor saying, "How are you today?" and the patient, as she said, being flustered and foggy and so on, trying to figure out what it is she wants to say, there's already a summary with highlights of where the problem areas are. And even if all the numbers are low and the ratings are very low, one can still say, is this okay? Does this really, reflect how things are going today? Just as a verification, it takes 2 seconds. It sounds like it's going to take a lot of time. Our clinicians were a little concerned that it would, we don't have time for this, et cetera, et cetera. These are valid reasons in very busy clinics. It turns out there have been some studies, time studies done, to show that it actually shortens the conversation time because the focus is right there. I couldn't see that. 10 minutes? So I'm just going to slow down because I'm actually on my second to last slide. Everybody okay? All right. So as Doris Howell, my very brilliant colleague in Toronto, along with Madeline Lee, who are my co-leads, has written, individual tailoring of care can be facilitated in this way, in real time. And the role that we have is to customize psychosocial and supportive care and patient activation that we have not yet fully realized. So it's about activating the patient, providing the patient with tools. I don't have time to go into all of the things that all the tools have been developed. We've been collecting pre and post measures because it's a quality initiative. It's not a research study per se, but the goal is to change the conversation and help the focus. And that's just to make me a little more nauseous than I am. So what are this is the last slide. What are our expected outcomes? We've just started a few weeks ago, and if you invite me next year, Susan, I'll be happy to come back. We'll have some hard data. The expected outcomes are immediately that will hopefully have impact on reducing symptom severity and distress because we'll be more targeted and we'll be evaluating more systematically. We'll be increasing the communication and the collaborative working team. We're taking measures through self-report of how the team actually is impacted by this through a scale that we have completed by the healthcare team. And the goal is to increase patient activation and involvement, all to improve the patient experience outcomes, which we're going to be measuring in an intermediate way. And the long-term outcome, as I said at the very beginning, is to use all of this information to hopefully standardize prom use, at least for these 4 symptoms, to reduce population rates for urgent care, acute care hospitalizations, and so on, because we'll be dealing with symptoms in a more timely manner. This is a cast of thousands. There's so many people to thank. I have my program manager, Adriana, and the symptom coordinator, Ashley, who are here, and all of the nurses and doctors here at the hospital and at the other hospitals who've been so useful and helpful. We've worked with them from the beginning in as collaborative a way as we can. All of this has been a process of engagement at the patient level and also at the healthcare team level. It was the patients and the doctors who designed the output form. It looked complicated. That's what they wanted. I would have made it simpler, and they said, no, we want all of this information. It was very important to have that collaboration, and that collaboration continues. The other soft piece of evidence I have is that I just asked Adriana how things went over the last couple of weeks, and she said the patients, as I said, are engaging well, and some physicians who initially have been skeptical, have been seeing what's been going on, have been asking to sign on. So that's really exciting news. And we hope to disseminate and move this throughout the cancer system, the Rossi network, over the next year and a half. Thank you very much.